Andrew Barrett again. Now, continuing on with our videos, we're going to talk about what we actually do for a reconstruction in the setting of an ACL. Important previous videos, hopefully you've seen, understand the mechanics, the anatomy, other associated injuries, but now we're getting to surgery, talk about the reconstruction, what we do, and the graft option. So let's just jump on in. So we've seen lots of MRIs so far. What we see in a complete tear in a young athlete is no ACL crossing the joint at all. We have that pivot injury from the knee shifting on the outer side. This should all make sense at this point. Once we've gotten physical therapy, the knee's moving again, good range of motion, swelling's down. Essentially, the knee should be as close to normal as possible, short of not being able to do pivoting sports. And not everyone needs an ACL reconstruction, but generally if you want to return to twisting, cutting, pivoting activities, or your job requires that, then usually ACL reconstruction is a superior result and the better way to go. Because if you continue to shift doing those activities, eventually you start to bang in that bone more, you tear the meniscus, tear the cartilage, and then we have a problem that went from really solvable to hard to treat. So when we see an ACL tear, again, a little review, at the time of surgery, we normally see the big ligament. When it's torn acutely, we see the frayed end of the rope, essentially. And then in a chronic ACL, there's just nothing crossing the knee joint because your body has absorbed that. A lot of time in surgery, or in clinic before surgery, we talked about graft options. So you can scan this QR code. It's a good review article, deep dive into the main options. And the main options are divided into two categories: autograft, your tissue; allograft, cadaver tissue. For your own tissue, there's bone, patellar tendon, bone, hamstring, and quadriceps. And this is just the type of tissue that we grab. So the if we look at the knee model here real fast, so the bone, patellar tendon, bone graft is taking a strip of your patellar tendon. Okay, so it's about 30 to 35 millimeters wide, and we take the central 10 millimeters associated with a block of bone on the tibial tubercle down here and a block of bone on the patella at the top here. So bone, patellar tendon, bone is why it's called that. Quad tendon is not taking bone, but up on the top part of the knee. There's a where your quads are coming into the knee, there's a thick tendon there. And this is about 55 millimeters across. And we take the central 10 millimeters of that. It's just a soft tissue graft. It's not bone associated with that one. And then what's not shown on the model is a hamstring graft. So the hamstrings come down the back of the knee, and there's multiple hamstrings. One crosses towards the front of the knee and actually inserts down kind of more towards the front of the knee. That one hamstring is the one that we take for this graft, along with an associated smaller tendon that's an adductor tendon. Other hamstrings attach in the back of the knee here, and then two over here. So you still have lots of hamstring still attached, but one of those tendons is sacrificed for it. Cadaver tissue is obviously not taking your own tissue. So there comes some benefits of that, obviously, of not damaging any other part of your knee to try to help your ACL. And let's talk about each one. So patellar tendon graft. So kind of the tried and true gold standard graft is a bone, patellar tendon, bone graft. It's been, misspell another word here. It's a strong graft, long track record, most used in professional sports. Graft still is the bone, patellar tendon graft. One of the advantages is that you get bone and bone healing on both sides. So remember, we make those tunnels we'll talk about, and you have bone healing into bone, which is the most reliable way for tissue to heal versus ligament into bone that we'll talk about with the other types. Return to sports, and generally this graft, the studies are a little bit all over the place. We're talking about a few little percentages here and there, so it's not a perfect science, but generally improved rates with return to sports relative to the hamstrings, and relative to hamstrings, a lower revision rate. But it does come at some risks. There's no perfect graft option. So there's disadvantages of anterior knee pain. Because we're taking bone chunks in the piece of bone in the front of the knee, kneeling pain can be up to 20% of people quite bothersome. Most people feel it to some degree, although can learn to tolerate it. But that's a big risk. So we often don't use these in laborers, people that kneel a lot for their job. Can't be used in skeletally immature patients. Since we're taking down by the growth plate, this actually interrupts the growth plate. And so we can't put bone graft through the tunnels of an ACL in a skeletally immature patient. So if you're not done growing yet, this isn't an option for you. A little bit of a larger surgery, usually more pain, a little bit more time, difficulty recovering compared to hamstring grafts, and possible higher risk of OA. OA is osteoarthritis. So people have associated getting this type of graft, even though it's higher function return to sports, even though it's a nice tried and true graft, possibly a higher rate of when you're older having arthritis that eventually needs a knee replacement. A hamstring autograft is where we take the soft tissue that we talked about that wraps around the knee. Does not impact the extensor mechanism, so the quad. One of the big things that we see at before surgery and after surgery is how much the quads shut down from the ACL surgery, or just the injury and then the surgery. And this has no effect on that since you're not touching the quad or the patellar tendon. The harvest site pain is quite minimal, very rare to have residual hamstring pain in the back of the leg. It can be used in skeletally immature patients. I consider this a smaller surgery, quicker, and just less intense than a patellar tendon graft surgery, so less postoperative knee pain. Disadvantages in small patients, sometimes the graft is small. Their hamstrings are proportionately small. For a patellar tendon, we can still get a normal size graft. For small patients, oftentimes we can't, or the size that the hamstring gives us is less than we want. We have to kind of consider that beforehand. If there's an MCL injury, we don't want to do any extra damage to the inner side of the knee, so we want to leave that hamstring a little bit longer for the graft to integrate into the bone than the bone healing that we talked about with the patellar tendon. And in certain high-risk patients, typically females, valgus knees, bad mechanics, already sort of loose, hyper-flexible knees, hamstrings are probably not the best option. And the reason why is if you have hypermobility already, those hamstrings are already a little bit sort of loose bungee cords. Now using those for the ACL, it's probably just not strong enough. So probably if you're looking to go back to high risk sports and you're a high risk patient, this is not my favorite graft. Quad tendon autograft, it's 10-ish years ago was kind of the new kid on the block. It's a little bit less of a track record than some of the other ones. The big advantage is that we do get a large graft with a large cross-sectional area. Just like ropes, if it's bigger, it's stronger. And this graft is generally pretty big. Relatively low harvest site pain, not the kneeling pain that we see with the patellar tendon, and it's harvested through a pretty tiny incision. Disadvantages, this really impacts the quad. Now, if you talk with physical therapists that deal with ACLs of grafts of all type, it is a longer slog to get that ACL or to get the quads firing again, being able to do a straight leg raise, getting the quads strength and therefore the stability back in the knee takes longer. It's also a soft tissue graft like a hamstring, so it takes a little bit of a longer incorporation time. There is an increased risk of what we call a cyclops lesion or post-operative stiffness in some patients. Because it's a big bulky graft being fit into a pretty narrow window, any extra little scar tissue that forms doesn't really have space to hide, and so they have a higher risk of needing at some point a little scar tissue debridement in the front of the knee. Not a big surgery, not a bad thing if it happens, because that usually means the graft's good and big and it's done well, but it is one of the risks. It has a little bit of a shorter track record. I've gone and taught to multiple surgeons how to do this graft, and there's definitely a learning curve to it. It's not as straightforward as the patellar tendon and the hamstring, so you gotta just make sure you find someone that knows how to do these. Cadaver tissue, obvious. If this graft was as good as the others strength-wise, no brainer. Let's use it, but it's not, because it has such good advantages. No graft harvest. We don't take anywhere else from your body. Very tiny surgery, 30-minute surgery. Predictable graft size, because we get to pick the size of the graft from the freezer or the tissue freezer where we hold these. We have endless supply. We can use many of them, especially this is where it comes into a multi-leg reconstruction. This is the people that tear their ACL, PCL, LCL, many ligaments around the knee. We run out of tissue if we're trying to use your own tissue, and so generally start going to cadaver tissue. Disadvantages, very small risk of infection. These days they're clean, sterilized. In the 80s, 90s, people were concerned about that. Doesn't seem to be a problem anymore. Delayed incorporation. So it's essentially a dead piece of tissue. So it takes longer for it to heal into the bone, to your body to use it as a scaffold to make a new ligament out of it. Active patients do have a higher failure rate, a lower return to sport versus using your own tissue. Generally used in revisions or lower activity patients or over 40. A lot of people, it's very regional around the country. If you go to the East Coast, a lot of people are using cadaver tissue in younger patients. I've done them in people in their 30s after consultation and discussion of sort of the pros and cons. Generally start to consider it more over 40, 45 into the 50s. But even an active person in their 40s, an active person even into their 50s, using their own tissue, if they want to do high-speed cutting and pivoting sports, probably still go away from cadaver tissue despite all of its advantages. So no single graft option. If you want to dive in deep, this QR code leads you to a review article that goes over all of this, essentially a lot what I talked about. We have to look at a lot of things in picking a graft, and that's why I do believe you should find a surgeon that does all of them, because there are pros and cons. So what do we do when we actually now have this graft? So again, ACL tear, we clean that up. It's no good anymore. You can see it doesn't have blood supply. It's torn. We can't fix that. So this is what an ACL reconstruction looks like. We have a tunnel that we drill in a very precise location through the tibia up into the joint. And then again, in a very precise location, this tunnel curves over to the outer side. In the femur, and these are at the exact anatomical locations of the previous ACL. And then we funnel the tendon through, the graft through, and then essentially what we call dock it onto both sides. So hold it onto both sides, pulling that graft through to remake the ACL. If you get an MRI afterwards, usually we don't need to, but in some circumstances we get them. We see that there's a new ACL that crosses across the knee joint. Here you can start to see a little bit of that tunnel. You can't really see the tunnel that's heading up that way into the femur there. So all the grafts look essentially the same. Once they're in the same orientation, all of that from quad, BTB, and hamstring, the concept is the same. Come into the joint, go out at the femur, and have it crossing the joint like the old ACL. Here are my numbers from the last few years. So again, I'm an advocate of finding a surgeon that does all of them, because I think since we all acknowledge that there's no best graft, that's well established, finding the best graft for you requires that consultation and discussion, and really sort of seeing the pros and cons. So I think a surgeon that does all of them makes sense. So these are my numbers in the last few years. Quad, BTB. I think BTB's gone up for me lately, but they're roughly equal. And then allograft, again, this is the cadaver tissue. That's in certain populations. The older, less active athletes, sometimes revision, sometimes, or just people that really don't want to, they're happy working out in the gym. They not that interested in cutting and pivoting sports and really just want to sort of get back quicker. An allograft is a good option. So afterwards, again, once it's in, normal ACL reconstruction look pretty similar. The surgical information, people are always wondering how long this takes. First, this is an x-ray of a bone patellar tendon bone graft, ACL, and you can see the tunnel here that we drilled into the tibia, tunnel up into the femur here. And actually, if you, it shows up on my screen, I'm not sure on yours, you can actually see the piece of bone that we harvested, and then the graft is what's going between those across the knee joint there. This is a little piece of metal that fixes it onto the femur side. This is a little washer that we use sometimes to fix it onto the tibial side. Yours might look different. It just depends on what we used for that reconstruction. Different grafts have different ways of fixing them, but the concept is the same. So allografts, it takes about 30 minutes for the surgery, and autografts is about 45 minutes to an hour, just depending on some other factors. A lot of times, if we're doing a meniscus repair, doing additional surgery, things that we'll talk about in other videos, that may make it 1 hour, 1.5 hours, but that's generally a straightforward ACL about the concept. So that's the surgical information for the ACL. A lot to think about with graft options. That's not an easy discussion. It's worth you doing your research and having a good conversation with your surgeon. And as always, let me know if that needs to be me. All right. Thanks for watching. Talk to you later.